Hello, Assalamu alaikum. I'm Dr. Nighat Kamar. Hope you are all doing well and fine in this difficult time. I think it's a better way to connect with your studies that we are giving lecture over here. I hope. Uh, hello, hello. सामने भी खाली देगा आवाज़ बहुत आ रही है मेरे इसमें आवाज़ बहुत आ रही है अनम्यूट किए कि hello sorry there's a lot of disturbance here मैम उनसे कहीं वो unmute करो
माइक ऑफ करें वो मैं डॉक्टर साहब के पीछे वो अपना माइक बंद हो गया
no sorry there's a lot of disturbance over here like I hope I think you can't say ask any question you can send your message in the comment box so today the lecture is basically the non-neoplastic disorders of the salivary gland and basically the thing which the today's learning outcomes at the end of this lecture we should you should know you should be able to know the anatomy of the salivary gland as well as we will discuss different diseases along with their clinical features and what are the treatments and the investigation modalities to confirm the diagnosis of those diseases. Now starting our lecture with the anatomy of the salivary glands. I hope you all know how many types, how many and what are the different types of these salivary glands in our body. But let us revise this, that they are basically the salivary glands. These are basically the exocrine glands that produce saliva through a system of ducts. Salivary glands and they can be classified according to their the basis of their secretions that they are either serous, mucinous or mixed glands in which both qualities of serous and mucinous glands are present. So basically serous glands, the main function of the serous gland is to produce the alpha granules and they take part basically in the digestion of the starch into the glucose. While in the case of mucinous gland, they produce the mucin, and which acts as a lubricant for this, that for our digestion. And to make it easy, we need saliva in our mouth. So there are actually basically two groups of the salivary glands. One is the major salivary glands, which include three basic salivary glands, that is the carotid, submandibular and sublingual, carotid being the largest one, and is that basically it is a serous gland, and clinically it is very important gland because it has got a very important nerve over here. It has, sorry, I think. So actually, as you can see in these images, that this is the parotid gland, and with this it has got a clinically important nerve which is called facial nerve, and which can be sacrificed during some surgical procedures. And it has got the important thing which is important is parotid duct, which opens into the opposite to the second molar tooth, and which is also called Stenson's duct. While in the case of the other gland is submandibular gland, and the duct which opens in the floor of the mouth is called Wharton's duct. And the sublingual gland has not a specific duct, but it has very few small ducts which open again in the side of the tongue. So these ducts are very important. Around 800 to 1000 minor salivary glands are present in the submucosa of different structures of the oral cavity, like buccal mucosa, soft palate. As you can see, these are all the different minor salivary glands, and these are again very important. Now coming to the next one, that now we are going to discuss the different diseases of the salivary gland. These most of the diseases are non-neoplastic, and we will discuss the tumors of the salivary glands in the next lecture. So the first comes, as you must have heard about the mumps and you must have experienced this is in your childhood. This is also called viral ferrotitis. Basically, mumps is an acute viral contagious infection which occurs due to the virus paramyxovirus. And the effect of this disease, basically the bilateral tender, and sometimes it is self-limiting disease most of the time. And important thing that it's basically this disease occurs most of the time in the case of school-going children, as well as those people who are present who are, working in a very closed environment, because it's a disease contracted by droplet infection and objects, all the different carrying agents like cloth, book. So that's why it is called a contagious disease. तो क्या करूं फिर? So intubation, and as I have already told you, that children are mostly affected, and school-going children. And incubation period of this disease 2 to 3 weeks, and of course, और ऊंचा, अच्छा, virus excreted through salivary, nasal, and urinary secretions. Now, what are the clinical features of this disease? As it occurs due to some virus. So, viral symptoms, as you must be knowing nowadays due to coronavirus, all viruses mostly have some viremia or same features. That is high-grade fever around 103 degrees Fahrenheit. Body aches, anorexia, muscular pain. But the most prominent sign is basically carotid swelling. Either it is unilateral or bilateral occurs. Most of the time, carotid glands are involved, but sometimes, submandibular as well as a sublingual gland can be enlarged during this disease. So, but this disease is not simple, although it is a self-limiting disease, and the symptoms can be recovered within 1 week, but complications can occur. And sometimes some are fatal complications could occur due to this disease. And but the common symptom which usually occurs in the young boys and girls are otitis and uveitis, and sometimes it occurs, it causes pancreatitis, as well as going into the brain. It can cause meningitis or meningoencephalitis, and the presentation of patient in that case would be headache, neck stiffness. And another important effect or complication of this disease is sensorineural hearing loss. And most of the patients, when you take history in a young, children with unilateral, most of the time unilateral, but sometimes it could be cause bilateral sensorineural hearing loss. And this sensorineural hearing loss basically occurs within a days, and this is called a sudden sensorineural hearing loss. And the other condition also, this mumps also affects on the thyroid as well as your heart, causes micromyocarditis, nephritis, arthritis. So I have written over here, these are mumps. You can memorize with these mnemonics, that so you can have some idea, because at sometimes you can get the question with all these complications. So then you would be able to solve that question. The next one is basically now coming to its diagnose. How we will diagnose this condition. Basically, the one which is clinical diagnosis, it is a clinical diagnosis by taking correct history and examination. You can easily diagnose that any patient is having this mumps. And but in the case of laboratory investigations, we can do, because if the patient is suffering with pancreatitis, then serum urinary amylase is increased during first week. And these immunoglobulins, they are very effective in getting, to know the diagnosis of mumps. IgG and IgM. IgG, as we know, that this basically this shows that it has got a patient has got a past history of the disease, as well as if the patient is not suffering right now with the disease and the immunity has been built in this patient. IgM always indicates a recent infection, that is acute infection, and it is almost it has been written that 100% of patients have IgM in day 5. Now, the treatment. Actually, this disease is most of the time it is self-limiting disease, but you can treat it with hydration or rest, and there's all the symptomatic treatment which we can take during the viral infections. So, of course, definitely, food which increases salivary flow should be avoided because whenever there's more of the saliva produced in our mouth, it will cause pain, and patient would have a little bit pain in their parotid swelling. Parotid swelling lasts for 1 week, but you need to look for the complication. How we can prevent this disease? The prevention would be uh, due to the MMR vaccine, that is measles, mumps, and rubella vaccines, and this vaccine, and actually this prevention is very limited. Initially, this is sometime, in ancient times, this is a fatal disease, but due to the invention of this MMR vaccine, which is given to the school-going children, actually basically 2 doses. One is before going to the school-going children, that is around 1 year, and one after school-going children, that is around 4 to 5 years. That is the booster dose. So now the next condition would be acute suppurative parotitis. Basically, as the name shows, suppurative parotitis, it means that there is a basically this is the inflammation of the parotid gland. Acute suppurative, as its name shows, that is the acute inflammation of the parotid gland, and which is also bacterial infection. There are different causes of this disease. That is basically the most important thing, that the microorganism which is involved in this disease is Staph aureus. While it could most of the occur in the patients who are who are having some immunity deficiency, immunodeficient host, as well as the dehydrated patients, or sometimes it also occur in the case of surgical procedures. It could occur, but also it also occurs in those patients who are basically immunocompromised patients. And some of the drugs, they are also taking part in getting this disease. So again, the presentation of the patient would be sudden onset, severe pain, and when we see the parotid gland, it is quite enlarged, and sometimes it is, presentation would be that there is a pussy discharge coming out of the, opening of their ducts. So as you can see in this case, this basal Stenson duct, which is also swollen, red, and pus coming out from it. And you can easily examine opposite to the second monitor upper. While investigations, of course, as any bacterial infection, we are going for blood complete picture, and it will show that there is an increased PLC count, as well as you can send blood and pus for the culture sensitivity, so you can easily prescribe the correct antibiotic for the patient. Uh, the treatment in this case, again, it is a bacterial infection. Keeping this in mind, we have to give the antibiotics, which should be most of the time is intravenous, and keeping the patient hydrated, as well as oral hygiene should be very good. And in some cases, if it does, medical treatment doesn't treat the patient, then we will go for surgical drainage and will open the duct, and so that in very rare cases we have to go for carotidectomy. Now, there's another condition that was the acute, basically salivinitis. This is another type is chronic salivinitis. Chronic salivinitis basically occur due to the recurrent infections of the salivary gland, and in this case, when it occurs repeatedly, then there is a periodic swelling. But in this case, definitely pain would be less, and fever is again less because it is a recurrent condition. And during the period of its expiration, the remission, the patient would be, all right during these episodes. And as we can see, but one thing at this point is that basically the as you can see, this is silography, silogram. This is a radiological investigation to see the position of the duct, thickness of the duct of these salivary glands. So in this case, and this is a differentiating point because this is a salivinitis, and then you need to differentiate this condition from the phylactesis, which is basically, as you can see in those two silograms, you can easily appreciate this thing that there is no dilatation or thickness of the duct. While in the case of phylactesis, you can see that there is a dilatation of the duct. So this Salivan is very helpful in differentiating salivinitis from the other diseases. Now, another cause of the salivary gland inflammation, dark granulomatous disease. Whenever there is infection of the any condition, then granulomatous disease would include in the differential diagnosis. And as we have, must go through all these granulomatous diseases, nothing new in these granulomatous diseases. The first is tuberculosis, the other one toxoplasmosis and actinomycosis. So again, tuberculosis in this case, the spread might be directly spread through the ductal spread or through the hematogenous spread. If there's any lung disease then it could spread to the parotid gland. Most of the time, again, in this case, parotid gland is enlarged. And what we can do, we will definitely go for all the routine tests, that is FNAC, as well as the PCR examination for the to detect the tuberculosis. And then, of course, we need to give the anti-tubercular therapy for this disease. And if needed, there's a tender lymph node or the tender mass is present, and then we will go for surgical excision of the involved tissue. Now, other toxoplasmosis is quite rare infection, and it occurs due to the Toxoplasma gondii. And basically, these tophites, they enter into the lymph nodes and they cause lymphadenopathy. And wherever there is a the presentation of the patient in most of the cases is lymphadenopathy. So we will definitely get the diagnosis. We'll go for lymph node biopsies. And again, the one good thing for this toxoplasmosis is it is a self-limited disease. But in those cases in which it does not, resolve itself, we'll go for a drug pyrimethamine, which is very quite effective in treating toxoplasmosis. Now, the other one is actinomycosis. Again, this occurs due to the dental infections. And the presentation of the patient would be, again, sometimes, discharging sinus. And when you will get the laboratory testing for that abscess, we'll have that this abscess basically contains sulfur granules. And this is one of the, diagnostic feature for the actinomycosis. And treatment would be again surgical as well as the post-op, penicillin as well as tetracycline cover for a long time. So the next disease is basically salivary calculi. As the name shows, calculi means there are stones present in the salivary gland, and the formation of this salivary gland, most 90% cases, this occurs in the submandibular ducts. So in few cases, it also occurs in the case of parotid gland, very few, and most of the time it is intraductal. And basically, this calculi is basically made up of calcium oxalate crystals. And these calcium oxalate crystals are, as you can see in this picture, of course, the presentation of the patient would be the difficulty in swallowing, as well as irritation with the presence of this hard swelling most of the time in the floor of the mouth, and the patient can easily palpate this most of the time. But in some cases, it is translucent and we can't see it. But again, good feature of this calcium oxalate crystal that it is easily identifiable in the silogram, and we can see the location as well as the extent of the stone in the floor of the mouth. Now, as we can see, patient can easily palpate this stone, and they can also identify the location of this stone in their mouth. Now, these are radiological features. Again, this is allogram, which is basically a radiological X-ray. And most of this, almost 90%, these are the stones are radio, we can easily visualize on the X-ray. But in the some cases, when they are radiolucent and ductal dilatation, then we will go for salivary as well. And now treatment again, of course, when there is a stone present inside the mouth and it is quite irritating throughout the time. Whenever you swallow anything, it will get swollen. Sometimes you need surgical treatment. Most of the time, you need to evacuate the stone, and smaller stones can easily be removed by the simple operating on the ducts while in the incision by taking incision and drainage. But in some cases, when when you can't find the stones, then we have to sacrifice the gland, and we'll go for salivary that is called removal of the submandibular gland. Now, the last one, that is Shogun syndrome. This is basically an autoimmune disease. As we all know, there's autoimmune diseases. They mostly occur in the females most of the time. But basically, this autoimmune disease, these autoantibodies, they act on two important structures. That is your eye as well as your mouth. So what will it cause? Basically, it results in the dry eyes and also that of the dry mouth. And this is the presentation of the most of the cases in patient present with these two findings. They are having dry mouth as well as continuous dry eyes. And this Shogun syndrome was first, basically described by many work has been done on this syndrome. But the most important, it was basically diagnosed by Henrik Shogun, which is an eye specialist, Swedish eye specialist. But this condition not only affects only on lacrimal gland as well as our mouth, but they also affect on other very important glands like lungs, skin, kidney. Wherever mucus is produced, then they will cause the dryness in those cases on those structures. And also this effect on the and sometimes patient presentation would be some kidney problems as well as pancreatitis. This might be the presentation in some of the cases. Now, this is a picture. I think you must have known the Williams sisters, and she's Venus Williams. And she has recently been diagnosed by 2011, and the very great thing that she has disclosed this thing to the whole world that she was suffering from because she has been misdiagnosed a long time. And then in 2011, she finally disclosed that she is suffering from Shogun syndrome, as she has got all these problems, that dry ears, dry mouth, as well as weakness and muscular atrophy. And these are the symptoms, but she was, as every autoimmune disease, because autoimmune diseases take a lot of time to diagnose. So she had the same problem. She was misdiagnosed. She was being managed for different conditions, but later on she was diagnosed and she got treatment. Again, one thing important for Sjogren's syndrome is this: that if it occurs in any person, then it has to be there for long life, for all their life. They have to, treat because there's absolutely no treatment for this condition, and it should be treated, symptomatic treatment. So this problem goes with their life. So the now coming to the pathogenesis of Sjogren syndrome, there are multiple factors are taking part in the pathogenesis, although one of the important things is that there's no cause autoimmune disease, as we have seen that autoimmune diseases don't have any specific cause for it. The multiple factors, they are taking part in this diseases. Sometimes environmental factors, some viruses, some patients, they present after getting or after having some viral infection, and then some of the environmental factors, hormones, and these are the genetics. In some of the cases, genetics plays an important role. So basically, again, it affects on our major important parts, eye and basically salivation, salivary gland. And what actually happens when we go for tissue analysis, basically there is a lymphocytic infiltration, a lot of cytokines. These are all inflammatory mediators present there. And the hallmark of this disease, Shogun syndrome, is that it has got association with the lymphoma. Now, lot of disturbance in it.
ਉਸ ਤੋਂ ਬਾਅਦ ਉਹਨਾਂ ਨੇ ਤੇਰੇ ਜਾਣ ਵਾਲੇ ਲੋਕ ਜਿਹੜੇ ਚਲੇ ਗਏ ਹਮੇਸ਼ਾ ਚਾਹੀਦਾ ਹਾਂ ਸ਼ੀਸ਼ੇ ਦੇਖਣੇ ਜਾ ਕੇ ਮੈਨੂੰ ਮੈਂ ਕਹਿੰਦਾ ਜ਼ਰੂਰਤ ਹੀ ਨਹੀਂ ਸ਼ੀਸ਼ੇ ਉਸ ਕੰਮ ਕਰਨ ਲੱਗ ਉਹਨਾਂ ਉੱਥੇ ਨਹੀਂ ਬਣਾ ਚਾਹੀਦਾ ਉਹਨਾਂ
अभी है ना 2 मिनट नहीं. So it is basically going to affect on the lacrimal gland, so causes that is called xerophthalmia, xerostomia while acting on the mouth, and there's of course the presentation is bilateral parotid swelling most of the time. So some features are extraglandular, like of course it affects, as you can see in this picture, it can affect on every part of the body, but mostly arthritis. It can cause lymphadenopathy, presentation, lung involvement, vasculitis, kidney, liver. It is basically again autoimmune disease. So the presentation could be and lymphoma. That's it is highlighted over here. That is basically the most important complication, very rare, but complication of the Shogun syndrome in some patients. And could be the presentation of splenomegaly and myositis. Now coming, it has got basically two types, that is primary Shogun syndrome and also the secondary type. Now what is the difference between two types? The basic difference is that primary, as the name shows, that it has got no association with any other disease. The presentation would be only, this is the again presentation, that is xerostomia, that is dry eyes, and the other one is xerophthalmia, so dry eyes as well as xerostomia. Oral secretion would be decreased in this case, parotid gland involvement, and this type is also called benign lymphoepithelial lesion of parotid or Nicole's disease. The other, as the name, this is secondary Shogun syndrome, and this secondary type, basically why it is called secondary, because it has got the, of course, primary symptoms of the Shogun syndrome, but it is associated with some other autoimmune connective tissue disorder like rheumatoid arthritis, as well as SLE, that is systemic lupus erythematosus. So again, along with xerostomia, xerostomia, and rheumatoid arthritis, as it is association with SLE and RA, so it occurs in 90% in females. Now, how we would diagnose Shogun syndrome? Again, the few as the symptoms, like there's a decreased lacrimal secretion as well as oral secretion. So we can easily go for Schirmer's test. You must have heard about Schirmer test. There's a simple strip which we can place in the eye, and it is placed there for 5 minutes, and after that we will see the secretions, the lacrimal secretion. If these lacrimal secretions are decreased from the around 5 ml or 5 ml, then this Schirmer test is positive for the dryness of the eyes, and there is a less functioning of the lacrimal gland. While in the case of course, we can also detect by amount of the mucus which is produced in the mouth. This is again helpful in getting this diagnosis. But these are small tests. So specific tests which is important over here, that of course it will have raised ESR. Why? Because it's a chronic condition. And if it is a secondary Shogun syndrome, then of course there is a positive rheumatoid factor as well as positive anti-nuclear antibody. So if we go for test, then anti-SSA and anti-SSB bodies are definitely one of the case. Again, we will go for biopsy. Biopsy from the lower lip for involvement of minor Salivary as well as for the prostate gland as well. Again, some measurements are the flow rate. This shows that there would be reduction of the production of the saliva in the mouth. Now, the treatment of Shogun syndrome, basically, there's no treatment for Shogun syndrome, and we need to take it as a for our whole life. So the symptomatic treatment as well as the palliative treatment, because it is involved our eyes, mouth. So we are going to use different solutions or different medicines just to treat our symptomatic, to get the symptomatic relief. So and only that we need to get our regular checkup for lymphomas. Now, basically treatment can be put into regime like general measures and the other systemic manifestation, how we will treat the systemic manifestation as well. So basically, for the treatment, again, we need to consult our ophthalmologist for treatment of the eyes, rheumatologist, the dentist, because in the case of Shogun syndrome, as this reduction of the saliva, then this the oral hygiene of the patient must be compromised, and there's later on with the passage of time, there are a lot of problems with our teeth. So we need to see a dentist, and we need to take plenty of water, and we can all take these general measures like chewing gum just to basically enhance our saliva or the mucus productions. Of course, dry climate, we should avoid dry climate because our skin, our mucus, everything has been dried in this condition. And this is very good that to avoid coffee and tea, carbonated drinks, because these are all conditions which are going to reduce our saliva, and that is not going to help because already we for the decreased salivation. So there we can take different measures. So basically, the first step is topical therapies. How we can, treat our oral dryness, ocular dryness, other Sika features. Sika features are basically these when it is associated with rheumatoid arthritis or SLE, then we need to treat those conditions as well. So basically, we need to treat in this case that we enhance our gustatory stimulation, and for this we can use different diseases like bethanacol, bromaxine. These are used for increased tear production. We need to use corticosteroids are helpful in the case of SLE, RA, cactus, and hydroxychloroquine. And you must be familiar nowadays because Trump has, said that this disease is very helpful in the case of corona. And nowadays in our hospital, we are using a lot of hydroxychloroquine to treat COVID-19 patients. Anyways, these are other medicines which are helpful to increase our salivary and tear production, that like interferon alpha, and some of the immunosuppressants, the medicine like cyclophosphamide, sulfasalazine. These are important in the case of systemic therapy. So these are basically in the case in which are different complications occur due to this Shogun syndrome. Now, I hope this lecture would be useful in knowing the non-neoplastic conditions of the salivary gland. And later on, the next lecture would cover the tumors of the salivary gland. So, I think we should revise a little bit. I will give you 5 minutes. So, you can answer me these questions. You can see in your screen. One is with reference to mumps, which of the following is true? Meningoencephalitis can precede Ferrotitis. Salivary gland involvement is limited to the carotids. Patient is not infectious prior to clinical carotid enlargement, and mumps or titus frequently leads to infertility. I'll discuss these questions with you after 5 minutes. The other one is the most common organism responsible for bacterial salivinitis are Pseudomonas aeruginosa, Streptococcus pneumoniae, E. coli, Bacteroides, and Staph aureus. Please answer these questions. Okay, we'll discuss these two questions over here, then we'll go the other one. The first is basically with reference to mumps, which of the following is true? The correct answer is basically meningoencephalitis can precede Ferrotitis. This is the correct answer because, as you know, this is one of the complications can precede to Ferrotitis, meningoencephalitis. The other one, the most common organism responsible for bacterial salivinitis is? That is Staph aureus. Now, the third one is, what are the treatment options for excessive salivation? Include all of the following except bilateral submandibular gland rerouting, bilateral submandibular gland excision with carotid gland ligation, sublingual gland excision, bilateral carotid gland duct and submandibular duct ligation, or use of glycospirolate. And one of the scenario question, we need to answer what is the diagnosis of this condition. And a female 50 years old presented in ENT with difficulty in swallowing for last 1 year. She also has dryness of eyes and mouth for last 6 months. Now she is presenting again with body aches and difficulty walking for last 2 months. So you need to tell me what is the diagnosis of this condition. And then, of course, if you know the diagnosis, then you will definitely know that what are the basically treatment options as well as the investigation modalities to diagnose this condition. in the case of treatment options for excessive salivation, include all of the following except basically, for excessive salivation, definitely we need bilateral submandibular gland dilating, bilateral submandibular gland excision with carotid gland ligation, and these are the basically treatment options for the excessive salivation. And but there is the correct answer is sublingual gland excision, because we don't need over here. The sublingual gland excision doesn't improve the doesn't treat the excessive salivation. And bilateral carotid gland duct and submandibular duct ligation definitely improves the treat the excessive salivation. And glycopyrrolide, this is one of the medicine, they are also used in the treatment of the salivation. So the correct answer is sublingual gland edema. Now the other question, scenario question, and it could come in your exams, in your prof, as well as in your written test. So these are this is a very clear scenario. Anyone who has answered? Let me check. Yes. Nishal Aisha, yes, this is very true. This is Shogun syndrome. Yes, the answer is absolutely correct. And this is Shogun syndrome. And if you understand Shogun syndrome, then you can easily tell me what is the treatment as well as the investigation, how we can just and sometimes this question can include what are the different types of the Shogun syndrome, and sometimes this could come a small second part of the question, but you need to basically the clinical features of this disease. Hope you have understood this lecture, and if you have any problem, I'm still waiting. You can easily tell me, or send me the message in chat box so I can answer over here. I'm still waiting. If you have any question, then you can send me. If you don't understand anything, please do let me know so I will answer over here. Okay, thank you so much. मीटिंग में ठीक है मैसेज आया ठीक क्या नहीं
ये मीडिया
ठीक है